And I thank the ISMPO for inviting me. It's a great honor to be with all of you. And my task is to give updates on GIT cancers. As you know, I mean, it encompasses a number of organs, and therefore, it's going to be a lot more to cover. Next slide. And a lot happened in 2020, mostly virtual as inevitably, ASCO, ESMO, and the GA Cancer Symposium. And there is so much data to kind of look at and see what we can get out of that. Next slide. So what I thought is there are lots and lots of data and update. So I thought at best I can present it as like breaking news. Probably try to give an overview of what has been most talked about in all these important discussions. And so if we ask what's the news in 2020 other than the COVID in the GIT cancer, we can probably, for the sake of discussion, divide them into immunotherapy based advances, targeted therapy based advances, and other updates. Next slide. The first one I picked is the adjuvant data, adjuvant nivolumab versus observation for neoadjuvant. This is the esophageal cancer and gastroesophageal junction, and this is the post neoadjuvant CTRT and resection. There is very little data in this area, gastroesophageal junction cancer and esophageal cancer post neoadjuvant CTRT, both in the adenocarcinoma setting and in the squamous cell setting. What do we do post surgery? We generally follow up. So let's see what this data says. Nivolumab versus placebo. Next slide. The DFS is the primary endpoint. The DFS with nivolumab is 22.4 months versus the placebo of 11.0. Next slide. So the Checkmate 567 concludes that there is statistically significant and clinically meaningful DFS improvement versus placebo in patients who are resected, esophageal and GE junction cancers following neoadjuvant CTRT. 31% reduction in the risk of recurrence or death. So they say that nivolumab could become a new standard of care. Next slide. When you look at what the experts think about this trial, is that this is the first trial that shows a benefit in the adjuvant immunotherapy setting in the resected esophageal and GE junction tumors for both adeno and squamous cell carcinoma histology. Robust DFS may be likely incorporated into clinical practice once it gains more approval. Next slide. Moving on to advanced setting. Next slide. Checkmate 649. This is first line nivolumab plus chemotherapy versus chemotherapy. And this is advanced gastroesophageal cancers. This includes both metastatic advanced gastric cancers and esophageal cancers and esophageal adenocarcinomas. And nivolumab plus oxaliplatin based chemotherapy as compared to chemotherapy alone. And current analysis is confined to this nivolumab versus chemotherapy subgroup. And there is another cohort which is Nivo EP doublet, but that will probably come later. Next slide. And OAS and PFS. And the median OAS with the addition of nivolumab with chemotherapy is 14 months as compared to 11 months, and a DFS of 7 months as compared to 6 months. Next slide. For patients who had a CPS of more than 5. This is with CPS of more than 1, you have again a superior OS and PFS, and this is for all randomized patients. This is 14 months versus 11 months is the OS. Next slide. And the overall response rate for Nivo plus chemo is 60% as compared to 45% with chemotherapy alone, and the overall response rate is significantly higher and statistically very significant. Next slide. The conclusions are that Nivo plus chemo significantly prolongs OS and PFS in patients who have a PDL1 CPS of more than 5, more than or equal to 5, co-primary endpoint. Next slide. Keynote 590, this is pembrolizumab plus chemotherapy, and this confines itself to the advanced esophageal cancers, pembrolizumab plus cisplatin 5FU. Next slide. And you see that the OS is again superior. The median OS is as 13.9 months as compared to 8.8 months. Next slide. And for OS in CPS more than 10, in all patients, you have a 13.5 months of overall survival as compared to chemotherapy alone, 9.4 months. Next slide. Both the OS and PFS favored pembrolizumab plus chemo in most patient subgroups. That's the key outcome of 590. Next slide. So the conclusion for 590 is that first-line pembro plus chemo is significantly superior, improved OS and PFS and ORR as compared to chemotherapy alone. Next slide. Both 649 and Keynote 590 would say that there is improved overall survival with the immunotherapy with chemotherapy in the first line advanced setting. So this is considered to be, they consider that this is a historic year for esophageal and gastric cancers. Next slide. Into colon cancer, Keynote 177, first line pembrolizumab versus chemotherapy in patients who are MSI high and pembrolizumab 200 milligram Q3 weekly as compared to investigator's choice of chemotherapy. Next slide. So what is the key primary endpoint? PFS. The PFS is superior at 6.45 months, median PFS at this point as compared to 8.2 months. Next slide. And the overall response rate of 43% as compared to 33%. And it must be also noted that 36% of the patients in chemotherapy arm crossed over to receive pembrolizumab. And 23% of these patients received pembrolizumab outside of the study, and overall survival analysis is still ongoing. Next slide. The duration of response also is something that is very pertinent whenever we talk about immune checkpoint inhibitors. In Keynote 177, the median duration of response for the pembrolizumab arm is not yet reached. Next slide. The other immunotherapy study that's very relevant in the GIT cancer is an advanced hepatocellular cancer, this IMbrave 150, atezolizumab plus bevacizumab. Next slide. As compared to sorafenib, and the OS and PFS, both are superior. The OS for the bevacizumab arm is not yet reached as compared to sorafenib of 13.2 months. Next slide. And the confirmed objective response rate is around 27 to 33% with the bevacizumab plus atezolizumab arm. Next slide. Now, moving from immunotherapy studies into targeted therapies, some of the most important studies to look at in the GIT cancers in this year is the Destiny gastric study, trastuzumab deruxtecan for HER2 positive advanced gastric or GE adenocarcinomas. Up till now, only TOGA is the standard of care for first line advanced diseases in this setting. There was no positive study post first line. All the data post first line were negative, and this is the first positive study in the second line setting. Next slide. Overall response rate of 51.3% as compared to 14% with the physician's choice of chemotherapy. Next slide. That's the OS and PFS, and the OS and PFS both are superior with the improved overall response rate, and OS. Trastuzumab deruxtecan probably will become the standard of care in the advanced progressed setting. Next slide. Moving on to KRAS mutations in cancers in particular, and in GIT cancers, we know that 30% of all cancers are associated with RAS mutation, but something interesting happened this year. Next slide. KRAS G12C, 3% of colorectal cancers. Next slide. So the drug of interest is sotorasib, 960 milligram. This is only a phase 2 trial, but something interesting, very first to happen in this particular mutation. So I picked this study. Next slide. And you see that there is a disease control rate of 70% plus as compared to, or even 90% as compared in the 960 milligram dose cohort. Next slide. And that's the waterfall plots for the tumor burden change with this particular drug. So this is one of the first few drugs that has shown that something targetable can be tried in the KRAS specific mutations. Next slide. The other important study for this year is the POLO maintenance olaparib for the metastatic pancreatic cancers. Next slide. This is the PFS and response with the olaparib maintenance arm. With olaparib, the PFS is 7.4 months as compared to 3.8 months with the placebo. Next slide. So all these are very exciting to hear, but do we really have implications for real life setting? And all these drugs are essentially expensive. So is it possible to do something with these drugs in our setting? I'll just briefly present some of our experiences in this year 2020 in GI cancers. I mean, reflecting on these studies, we tried to follow these studies and see how we can incorporate these data set to our patients. And the challenge was to pick the right patients for each of these setting and see whether the results can be reproduced in our setting. I'll just present a couple of patients. Next slide. In the hepatocellular carcinoma setting. Next slide. This is a patient of us, 84-year-old gentleman, advanced hepatocellular carcinoma, who initially had RFAs and radiofrequency ablations, and then progressed on that. And chemotherapy was not a choice, and he was not preferring TKIs based on the adverse event profile. Well-read PhD professor, and we put him on atezolizumab plus bevacizumab, May 2020, and you can see the excellent response radiological in September 2020. Next slide. Colon cancer, first line. Next slide. And this patient has got a right-sided colonic disease with a very high tumor burden, and the doctor does not want any of the systemic therapies. Elderly patient, and you could see that after 4 cycles of single agent pembrolizumab, he has got MSI high disease, an excellent partial response, excellent clinical response, and his quality of life is much better now. Next slide. This is another patient of us who we are treating from 2000 to 2020, who has already had multiple lines KRAS positive disease in colonic cancer, and has gone on to receive multiple cycles of chemotherapy plus bevacizumab, and had progression in 2018. Next slide. And in 2018, early February 2018, this is the NGS report that shows a very MSI high disease with a tumor mutation burden of 51. So at that point, the the pembro data, even in advanced setting, was just emerging, and so we thought he was a right patient, very young man, around 38 at that point. We've exhausted all options. We have put him on, and you can see that he is still KRAS positive in the NGS. Next slide. We put him on pembrolizumab, and excellent response to pembrolizumab. He was very sick, and now he's extremely well with a very good quality of life, and he's back to normal. And he has finished his all quota of money, and then he has finished all the compassionate access program, more than 36 doses of pembrolizumab, and we don't know what to do with him. He's doing very well. Company doesn't know what to do with him. That's the situation. Next slide. Next slide. This is a gastric cancer disease, advanced disease, HER2 positive disease. Next slide. And you can see that primary, and you can also see the liver secondaries. Next slide. Trastuzumab based therapy with oxaliplatin based therapy, excellent response, both primary and the liver disease. Next slide. He went on to get surgery also, and then it was pathological CR, but that was again his choice. family of surgeons, and he is continuing on. Last slide. He is still continuing on trastuzumab. Next slide. This is our patient who had an advanced pancreatic disease, BRCA positive disease, and an excellent response with 12 cycles of FOLFIRINOX. Next slide. And you can see the very good response both in the primary and also in the liver side. And this patient is on maintenance olaparib, already crossed 6 months of maintenance olaparib. Next slide. So I have tried to I've tried to present in a short time, 15 minutes, what was all breaking news in GIT cancer for this year 2020. I think I could bring what is the most juicy part of the studies, and I must say that apart from that, this gentleman will be missing from the scene, and there will be less breaking news, in the US, I suppose. Thank you so much for this opportunity. Thank you for listening.